Okay, good morning. I hope all of you can hear me okay. Thank you again for joining us this morning for the next in the COVID 2020 lecture series. I'm Jennifer Yang. I'm the Program Director and a Pediatric Urologist at UC Davis, and we'll be talking about Genitourinary Pediatric Oncology today. Joining me, I have Dr. Philip Hsiao. He's one of our PGY4 residents. He's going to be helping me to moderate the session. I did want to thank all the support staff, Kirsty and Michelle from UCSF for really helping with all the logistics, and also for Claire De La Calle, who is one of the PGY5 UCSF residents who's also here in support. Hopefully you guys are all doing well. I'm very appreciative of the time and opportunity to connect with you, to share some education, as well as to help support each other in these times. I have no relevant disclosures to make. So just a basic overview of what we're going to be doing today. We're going to be covering the Genitourinary Pediatric Oncology section of the AUA core curriculum, and it's basically covering 3 different tumor types. The first will be WILMS tumor, then we'll cover a section on pediatric tumors, and we'll follow that with a section on rhabdomyosaurcomas in the pediatric population. I have included a few polling questions, which will hopefully allow us to do some interaction throughout the presentation, and we'll try to reserve the last 10 to 15 minutes of our session today for questions which the participants can put into the question and answer chat. I did want to tell a little story about myself. I was actually a resident at New York Presbyterian Hospital Cornell in New York City, where there's a basically it's an entirely COVID hospital. And I am definitely thinking of my friends, colleagues, and family who are in the New York area, and all of you who are out there, and I hope that you guys are well. I actually did see my first WILMS tumor patient as a PGY5 resident, and did the radical nephrectomy and lymph node dissection with Dr. Dix Pappas. So this definitely is something that is not common. These tumors are not common, but something that is definitely memorable. Okay, so we're going to get started with WILMS tumor. WILMS tumors originate from abnormal proliferation of metanephric blastema. And you'll see throughout my presentation, I have included a lot of histological slides. I understand that the in-service and board exams no longer include histopathology, but I do think it is really important in trying to understand the picture both of how it's treated and understanding some of the pathognomonic phrases that you'll see with these pediatric oncologic cases. So you can see on the slide there, the pathology for WILMS tumor is typically triphasic, and this means it includes components of blastema, stroma, and epithelium. And you can see on the slide there that in the center, there are all these blastemal cells that are trying to form rosettes, and it's surrounded by epithelium. And then you can see some myxoid stroma that's in between. WILMS tumor is the most common pediatric urologic tumor and represents 80% of all pediatric urologic solid tumors. Epidemiology, I think, is really quite important. It's important when you're reading exam questions to take note of the patient's age as well as their gender and any other identifying factors, because this will really help you overall in trying to decipher what type of tumor, and then based on that, what is going to be the treatment strategy and basically the way to figure out the correct answer for your question. So for WILMS tumor, median age is going to be 3.5 years, and the male to female distribution is equal. Majority of patients are going to be less than 5 years of age, and to remember that WILMS tumor is exceedingly rare in infants. And so if you hear about a renal tumor in an infant, especially less than 3 months old, you need to be thinking about congenital mesoblastic nephroma. Now, this isn't mentioned in the core curriculum, but I thought I would just bring this up. This is a tumor that's usually detected on prenatal ultrasound. You can see from these examples of the fetal ultrasound, the top picture is showing the kidney with a large sort of encapsulated tumor that's definitely more vascular. And these patients typically have polyhydramnios. They can have issues with hypertension and are often born premature. And typically surgical resection is curative, and there's almost no cases described of metastatic disease for congenital mesoblasthic nephroma. If you do have a scenario or a case, a patient that presents and they're over 10 years of age, you should also consider other etiologies that might be mimicking a WILMS tumor, such as other renal tumors, a renal cell carcinoma. You can have urothelial tumors as well. And then other non-oncologic origins, such as an abscess or a segmental pyelonephritis. In terms of risk factors for WILMS, just remember that the vast majority of WILMS tumors are going to be sporadic in nature, but there are approximately 10% which are associated with congenital syndromes. And the way to think about the congenital syndromes for WILMS, you can break them down by either a syndrome associated with somatic overgrowth, and this includes Beckwith-Wiedemann syndrome and hemihypertrophy. And these syndromes are associated with an abnormal chromosome imprinting on chromosome 11p15. And the other subcategory is going to be the syndromes that are don't feature somatic overgrowth. And the typical syndromes that we think of in this group would be Dennis-Strass syndrome or WAGR. And these are usually associated with the WT gene, which is on 11p13. You can see from the chart on the side of the slide that there is a differing risk for tumor formation in these groups, and it is recommended that for high-risk patients, such as those with Perlman, Dennis-Strass, or WAGR, they need to be screened every 3 months with an abdominal ultrasound until they're 8 years of age. So this brings us to our first polling question of the day. I'm going to go ahead and read it. Which of the following is not a feature of Beckwith-Wiedemann syndrome? Is it neonatal hypoglycemia, aniridia, microglossia, midline defects, or ear creases? And we'll give you guys about 20 to 25 seconds to select your answer. Okay, so looks like about half of you replied the correct answer, which is B, aniridia. Aniridia is going to be a feature of the WAGR syndrome, and if you guys remember, WAGR stands for WILMS tumor. Aniridia, the G represents genital abnormalities or ambiguity, and then the R is for developmental delay, or what they used to call mental retardation. So. Okay, so let's move on and finish talking about WILMS. So we'll speak briefly on other risk factors in addition to syndromes that affect the prognosis and overall risk stratification for WILMS tumor. One of them is going to be a biomarker, the loss of heterozygosity on chromosome 16q or 1p, which does portend a worse prognosis. Anaplasia, that's noted on histopathology, is going to be one of the most significant predictors of increased risk for relapse or death. And then there is a discussion about nephrogenic rests, which are abnormally retained embryonic kidney precursor cells. And these precursor cells may undergo maturation, sclerosis, involution, or complete disappearance. They are noted in approximately 1/3 of patients with unilateral WILMS tumor and 100% of patients with bilateral WILMS tumor. and they can be found incidentally in infants undergoing postmortem examination. The diagram that you see to the right of the slide depicts the two subtypes of nephrogenic rests, including the intralobar nephrogenic rests, which tend to form sooner, and those are the ones that are associated with the syndromes with that somatic growth is not a feature of, versus the perilobar nephrogenic rests, which tend to form around the renal lobe and are more commonly associated with Beckwith-Wiedemann and hemihypertrophy. So clinical presentation for these WILMS patients, as mentioned before, they're usually less than 5 years of age, and median age is 3.5 years. There is a clinical triad. Most patients do present with abdominal mass, and we used to emphasize that this abdominal mass is typically on one side and doesn't cross the midline, and this is to differentiate between a WILMS tumor versus a neuroblastoma. Some patients can also have hematurure pain. Other associated symptoms include hypertension and be looking for things on physical exam that might represent a syndrome. I put two examples here to the side. The top picture is a picture of a child with hemihypertrophy, where you can tell one side of the body is larger than the other side. And then the bottom picture is just a nice example of sporadic aniridia. Workup of these patients include CBC Chem panel LFTs. Preoperative imaging is important, mostly because it allows us to understand the extent of the tumor and also to look at the contralateral kidney to ensure that there's no other concerning disease on that other kidney. We do also pursue a rule out metastases workup, including a chest X-ray or a CT of the chest to rule out pulmonary disease. So when we talk about treatment for WILMS tumor, we're going to be following the Children's Oncology Group protocols, and here in the United States, that pretty much means upfront surgery. So for WILMS tumor stages 1 through 4, the initial treatment is going to be radical nephrectomy. And at that time, also a limited lymph node sampling. And as mentioned before, the contralateral kidney does not need to be explored at the time of radical nephrectomy as long as the preoperative CT or MRI demonstrates a normal kidney. One thing to be careful of for surgeons that are operating on patients with WILMS tumors, that intraoperative tumor spillage does result in upstaging or requires additional treatment with abdominal radiation. So the current spillage rate for that's documented in most of the trials for the Children's Oncology Group is about 10%. It's obviously more common with larger tumors. So overall treatment strategies from these cooperative groups has resulted in a dramatically improved survival for most patients, above 90% of all stages. Again, preoperative biopsy is not indicated. In fact, if there is a preoperative biopsy, it is an equivalent of tumor spillage and does require an upstage. Preoperative chemotherapy under the COG protocols is reserved for patients that have bilateral tumors, syndromic patients, any patients with solitary kidneys, and then further risk stratification will determine the actual treatment protocol, which typically includes multi-agent chemotherapy and radiation. If there is a patient with WILMS tumor, you should contact the primary investigator at your institution to understand what the current treatment protocols are. There's also information on these contacts on the Society for Pediatric Urology website. And then just one last slide for WILMS tumor about some different trends. The role of laparoscopic or minimally invasive surgery is really reserved for patients with smaller tumors and after they have received chemotherapy. I'd say the vast majority of patients are still receiving large transverse abdominal or thoracoabdominal incisions, and a flank incision isn't really appropriate. So there is a very nice video on the core curriculum page actually several nice videos of a radical nephrectomy for WILMS, so be sure to check those out. Regarding the role of partial nephrectomy in non-syndromic unilateral patients, it's not currently supported. In the initial studies looking at partial nephrectomy in syndromic patients, there was a greater than expected tumor spillage rate and a more significant microscopic residual disease. So this is not something that is recommended, and most of the momentum towards partial nephrectomy comes from the adult literature regarding partial nephrectomy in the patients with RRC, which can provide adequate oncologic control but still spare nephrons, but this is not supported in WILMS tumor patients right now. And some of the newer protocols are looking at very low risk patients that can be treated with surgery alone. And these include patients that are less than 2 years of age with favorable histology and a tumor weight that's less than 500 grams. And this is really to sort of prevent the long-term complications of chemotherapy and radiation in this population. So we're going to go ahead and move on to testicular tumors in the pediatric population. They're a very wide group of and different group of tumor types. It does represent 1 to 2% of all pediatric solid tumors. The annual incidence is approximately 1 in 100,000. Majority of these tumors are going to again occur in patients between the age of 2 and 4 years. And unlike adult testicular tumors, the vast majority of pediatric testicular tumors are going to be benign. And the reason that the literature represents a wider spread between 38 to 74% of cases is because some of the benign cases are probably underrepresented. Metastasis is pretty rare. It usually occurs in less than 15% of all tumors, and it can be to either lymph nodes, hematogenous, or both. And you can see these are some just nice pictures from the core curriculum looking at different pathologic specimens. So we all know the risk factors for testis cancer in adults, and this includes cryptorchidism. We now know that the age of orchiopexy is actually very important in terms of the risk for developing a testicular tumor down the line. And after review of several meta-analyses that were published a number of years ago, it does appear that the age of orchiopexy over beyond puberty is going to be your highest risk factor. In addition to cryptorchidism, there is also family history of testicular cancer, a personal history of testicular cancer, and the presence of intratubular germ cell neoplasia. In the pediatric population, it's a little bit different. Most of the risk that's associated with pediatric tumors has to do with the history of disorders of sexual development. There is an increased risk of gonadal tumors in this patient population, and the highest risk is going to be for those that have hypovirilization and the presence of a dysgenetic gonad. Intratubular germ cell neoplasia has been noted in 6% of children with DSD, with an even higher incidence after puberty, and in fact the risk increases to approximately 10% as the patients go past 20 years of age. I just put this example of a study where they are looking at why this is the case, and many of the researchers in this area believe that because of the dysgenetic gonad, if you look at the schematic of the hypothalamic pituitary axis, that because the gonad is dysgenetic, there then is an upregulation of your FSH and LH, and they've actually found in some of these studies that when they look at the level of FSH and LH in these patients, the higher and more abnormal these gonadotropes are, the more the higher the incidence of having intratubular germ cell neoplasia in these specimens. So this is just a chart of the different classifications that, and it helps you to sort of organize in your mind for pediatric testicular tumors, the difference between either a germ cell tumor, and examples for germ cell tumor for benign include a teratoma or an epidermal cyst. and then malignant would be a yolk sac tumor. For gonadal stromal tumors, benign tumors are Leydig cell and juvenile granulosa cell tumors, and the Sertoli cells could possibly be placed into the benign category, but I did put this on the malignant side for this particular slide. And then there are paratesticular tumors. Rhabdomyosarcoma, we're obviously going to speak about at the end of the next section of my talk. And then there are benign tumors in the paratesticular region, including a lipoma or a leiomyoma. So just a couple of quick facts to sort of remind ourselves about the pediatric testicular tumor. Most common type is going to be a germ cell tumor, and the most common benign type of tumor is going to be a teratoma, okay? And this is the reason why the most common type of pediatric tumor is a germ cell tumor, because the teratoma is a germ cell tumor. The most common malignant tumor in prepubertal boys is going to be your yolk sac tumor, okay? This is a study from National Children's that looked at the sort of characteristics of tumor proportions by type and age in a subset of patients. And you can see from the pie chart that the vast majority are going to be, over 40% are going to be teratoma and the epidermoid cyst. And this is the represents the benign tumors, but there is still a significant showing of the yolk sac tumors. And you can see by the distribution of this bar graph here that, again, majority of the patients are going to be less between 2 to 4 years and definitely less than 5 years of age. So presentation is usually a painless testicular mass. It sometimes can be associated with other types of pathology, including a hernia or hydrocele. And typically, providers will order a testicular ultrasound to better delineate what is being felt on their physical exam. And just to remember, obviously, that the testicular ultrasound cannot reliably distinguish between benign and malignant tumors. And typically there is no role for biopsy of these tumors. We would treat them and work them up the same, but not biopsy them before surgical treatment. So in your workup, you may do the testicular ultrasound as mentioned, and even though you can't necessarily tell if it's benign or malignant, there are certain features that you can see on ultrasound that might be suggestive of a benign appearing tumor. And it can be cystic areas, either one large cyst, or you can see cystic dysplasia associated with a teratoma or a cystic granulosa tumor. You can also see something like this, which we'll review a little bit later. This is a very characteristic appearance of an epidermoid cyst. And the other thing that ultrasound is useful to see is that when you see something that looks benign, if you're able to have enough of the intervening parenchyma, that still might make this a candidate for a testicular salvage procedure or a partial orchiectomy. Workup should also include tumor markers, obviously serum AFP. Yolk cell tumors invariably produce AFP, and the other tumors, teratomas and other benign lesions, are usually associated with normal AFP values. And just remember, in infants, typically they have elevated AFP levels until about after 8 months. I did put this table at the bottom of your slide that just reminds you of the half-life and other different details of the various tumor markers, which are still important to understand. Beta-HCG is common in mixed germ cell tumors and embryonal tumors, but rarely elevated in the pediatric population. Okay, so we're going to speak specifically about some of these different subtypes just briefly. So yolk sac tumor, as you may recall, is going to be the most common type of malignant tumor in prepubertal patients. Its initial treatment is going to be your radical inguinal orchiectomy, and metastatic workup does reveal pulmonary metastases in about 20% of patients and retroperitoneal metastases in 4 to 6% of the patients. Stage 1 disease, which is the vast majority of patients, they do not require additional chemotherapy. they will be on an active surveillance protocol. Stage 2, 3, and 4 obviously do require chemotherapy, often for the more advanced stages with multiple agents. I did again put up this pathognomonic histology picture that I want you guys to remember. And this is a Schiller-Duval body, and it's basically a cluster of tumor cells that's surrounding a central blood vessel. And then on the periphery, you can see the tumor vessel, the tumor cells are kind of flattened on the outside, okay? Moving on to teratoma. Once again, majority of benign tumors on ultrasound can have a variable appearance. Sometimes it can look very homogeneous, anechoic, but there can be also some complexity with alternating cystic lesions surrounded by highly echogenic signals. Again, tumor markers are typically negative. Treatment is going to be either radical or partial orchiectomy, as long as you can confirm by frozen section what the diagnosis is. So in the prepubertal setting, usually excision is sufficient. And I just put slides up here, different examples of components of the teratoma that you may see, including cartilage, squamous epithelium, and intestinal type glands. Immature teratoma is less common and is usually benign. And you'll see instead of the mature cell types that you'll see in a mature teratoma, you'll see other types of histology which represent more immature or potentially malignant cell types. You can see islands of small hyperchromatic cells, and this is a primitive neuroepithelium appearing tissue as well as primitive glands. Usually you do radical resection with a radical inguinal orchiectomy, and only salvage chemotherapy if there is a concern for malignancy, metastatic potential. Epidermoid cyst is going to be your monodermal teratoma, and it's usually differentiated squamous line cysts, and it has a very characteristic appearance, as we already saw on the previous slide. And what you're seeing is concentric rings of alternating hypo and hyperechoic layers, and it's called a onion skin appearance. Your AFP levels are going to be normal, and then you can see on the ultrasound that usually there is no Doppler flow within that tumor. The gross specimen is also very characteristic. It is very amenable to nucleation at the time of partial orchiectomy, and you can see the keratinous filled debris on the pathologic specimen on the lower right-hand corner. So just to mention briefly, because there is a lot of information in this section of the AA core curriculum, these are some of the other testicular tumors that are mentioned, and I tried to just summarize it in one word or phrase. So when you think about the other germ cell tumors that are out there, seminoma is really uncommon in the pediatric population and is typically associated with a patient that has a DSD. Usually treatment is going to follow whatever you would do for an adult seminoma. For another type of germ cell tumor, gonadoblastoma is considered a precancerous lesion in patients that have history of DSD in the presence of a Y chromosome. If it does have malignant features, it then becomes a dysgerminoma. In the second box, you'll see listed there some very common stromal tumors. The most common stromal tumor is going to be your Leydig cell tumor. And these patients, in addition to presenting with a painless testicular mass, also can present with precocious puberty. So if that's also evident on your workup, you need to include a hormone panel. They are typically benign and can be managed with either partial or radical orchiectomy. Sertoli cell tumors are also the second most common stromal tumors in the pediatric population, and they may be associated with genetic syndromes. They're fairly rare, rarely metastasize, and can be managed the same with a testicular sparing procedure. And then in neonates, the most common stromal tumor is going to be your juvenile granulosa cell tumor. Just one mention of the testis as one of the more common sites for metastatic spread for leukemia and lymphoma. And for AL patients that have relapse, about 20% of them will relapse within their testicles, and so that's something to be aware of. Oh, and I wanted to bring up one more picture here, and this is a histologic picture of a Leydig cell tumor. It has these inclusion eosinophilic bodies within the cytoplasm, and these are very, very important. Like, you won't be seeing these on any types of exam questions, but you do need to remember these as something that's common for Leydig cell tumor. So that does bring us to our second polling question of the day. And this is a little bit long, so maybe we'll give you a little bit more time to read through the question, but it says, a 2-year-old boy presents with a painless testicular mass. A transscrotal biopsy is done, and pathology reveals a yolk sac tumor. The AFP is elevated, and the CT abdomen pelvis is negative for metastatic disease. After initial radical orchiectomy, what would be the most appropriate next step in treatment? Would it be observation only with serial exams, tumor markers and imaging? Would it be a hemiscrotectomy, or systemic chemotherapy with 3 cycles of cisplatin, etoposide, and bleomycin, or RPL&D after the AFP normalizes, or none of the above? And I appreciate you guys for really focusing. I know this was a longer question, so we'll give you a few minutes. Okay, that probably wasn't a few minutes, but in interest of time, let's see what our results show. So most of you selected observation, and this was me, the question writer, trying to trip you up. The reason is I included that biopsy was done, which is very unusual, but it does happen, okay, because these type of processes are very rare, and sometimes providers who aren't familiar with pediatric testicular tumors will recommend biopsy. And if that is done, it does require an upstaging. And so the correct answer is actually C, systemic chemotherapy. Okay, so if the biopsy hadn't been done, answer A would have been correct. All right, so this brings us to our last portion of our talk this morning. We're going to talk about rhabdomyosarcoma. Rhabdomyosarcoma is the most common pediatric soft tissue sarcoma. It does tend to be very aggressive in nature and is derived from embryonic mesenchymal tissue, mostly striated muscle cells. It mostly affects the trunk and extremities, but it can arise in the GU system, accounting for approximately 20% of patients. And the more common sites would be bladder, prostate, followed by paratesticular, and then vaginal uterine are going to be more rare. We do see a bimodal distribution. There is a peak between the years of 2 and 4 years of age, and then another peak in the later teenage years. There's a slight male predominance with the male to female ratio of 1, I'm sorry, that should read 1 to 1.3. So the Children's Oncology Group does recognize 3 subtypes of tumor histology for rhabdomyosarcoma. This includes embryonal, which does portend a more favorable prognosis and is more common in younger children, versus the alveolar, which does have a poor prognosis. They have identified a fusion gene, which is present in up to 80% of the alveolar subtype patients. And this is seen as a translocation between the PAX3 or 7 gene and the FOXO1. The last subtype would be the anaplastic or undifferentiated. I just put here this Kaplan-Meier curve that was a part of this study looking at the fusion gene status in this particular subtype of alveolar rhabdomyosarcoma in comparison to the embryonal subtype. And you can see that those that have a fusion gene negative, their clinical behavior and their outcomes are very similar to those of the embryonal rhabdomyosarcoma. And so the fusion gene is definitely a very important prognostic factor for the alveolar patients. Risk factors for actually developing rhabdomyosarcoma in patients' history include advanced maternal age, either high birth weight or large for gestational age. Interestingly, a history of maternal drug use and exposure to radiation can increase your risk of a rhabdomyosarcoma. And there are a few associated known genetic orders, although the majority of these tumors are going to be sporadic. They can be affiliated with neurofibromatosis type 1 or the Li-Fraumeni syndrome. Interestingly, atopic conditions like allergies, eczema, and allergic reactions tend to be protective. And so there may be some relationship between immune-related factors and the development of these type of tumors, which is undergoing further investigation by the Children's Oncology Group. Clinical presentation for these patients, obviously for vaginal and paratesticular tumors, they have an earlier presentation because these tumors are more visual or more easily visualized or palpated, but because of the very centralized location of a bladder prostate tumor, they usually present later with urinary retention, gross hematuria, and other types of voiding symptoms. They can also present with constipation. You can see from the pictures of this bladder rhabdomyosarcoma how it can definitely impede and cause outlet obstruction. Natural history for most of these patients is a rapid growth and invasion with hematologous metastases and regional lymph node involvement. Other prognostic factors to consider for patients with rhabdomyosarcoma include age. So this is very important because patients that are over the age of 10 years have a worse prognosis. We discussed tumor histology as being important. Embryonal is also, as mentioned before, favorable. Especially the Botroids variant. There is a different prognosis for anatomic site, with vaginal paratesticular being better than bladder prostate. And obviously tumor burden and stage are important, and fusion gene status, as mentioned before. So some just general principles about treatment of rhabdomyosarcoma in the pediatric population. Metastatic workup is usually completed for all patients, and this is going to include either a CT scan or MRI to better delineate the primary tumor, as well as local spread or lymphatic spread. It should also include a CT scan of the chest, and most patients to this date are still getting bone marrow biopsies as well as bone scans to fully assess their workup, although there may be a subset of patients who are lower risk that don't require bone marrow biopsy, but at this time it's still recommended. Complete surgical resection is not generally done unless there's a possibility for organ sparing. So typically for most of these patients, your initial objective is going to just be to get a biopsy for diagnosis and to know histology and fusion gene status to further risk stratify these patients. Delayed primary excision could be considered after chemotherapy because it does help to reduce the radiation dose that these patients require for local control. If there's a high-risk patient with viable tumor, you could consider really aggressive or heroic pelvic exoneration, but that's rarely done these days. So what you really need to remember for rhabdomyosarcoma is it should be a multimodal therapy with organ preservation. And we're going to go through each of the subsets just a little bit more in detail. So gynecological rhabdomyosarcoma typically presents with either a mass or vaginal bleeding. Okay. Usually you can biopsy, obviously, the tumor for your tissue diagnosis, or consider complete resection if organ sparing is achievable, although the majority of the recent studies looking at gynecological rhabdomyosarcoma really do highlight and emphasize the treatability of these tumors without surgical intervention. And typically, pelvic lymph node dissection is not necessary. The Children's Oncology Group protocol includes primary chemotherapy and radiation for local control plus or minus surgical excision, and the overall survival at 5 years is generally good at 82%. I just have a picture here of the cluster of grapes that you may have heard or read about in the boitroid version of the rhabdomyosarcoma, and this is just a picture, a histologic picture looking at the hypercellular subepithelial layer that you'll see here in the intact squamous epithelium. So for bladder prostate, initially for diagnosis, you can achieve this through endoscopy with a TUR. But if there is any difficulty from that realm, an open transvesical approach for biopsy is recommended. And at that time, pelvic and para-aortic lymph node sampling can also be achieved. CT scan is useful for assessment of regional lymph nodes if the open biopsy cannot be done. But if there is an abnormal lymph node, it does require some type of histologic specimen to be able to adequately risk stratify these patients. Some things to note is that after chemotherapy and radiation, sometimes residual masses do not represent viable tumor. And this is to, again, support the organ preservation, or basically not trying to recommend aggressive or heroic surgery in some of these patients. What seems like a tumor could just be surrounding stroma that has collapsed after the tumor itself involuted, or sometimes the tumors can mature into mature rhabdomyoblasts and only require observation. So with these trends of organ sparing, overall survival through the years has been fairly stable at 78 to 83% for these patients. Lastly, we'll talk about paratesticular rhabdomyosarcoma. These account for 7 to 10% of the rhabdomyosarcomas that we see in the pediatric population. And they typically arise from the distal portion of the spermatic cord, and once again present as a painless scrotal swelling and a mass that's usually distinct from the testicle. And you can usually see the testicle is completely separated, as you can see from these bottom images on the ultrasound. Often there's an associated hydrocele. You know that the tumor itself is typically heterogeneous and very vascular. Initial treatment is going to be with radical inguinal orchiectomy. And at diagnosis, the vast majority of patients are going to be considered stage 1. And because of this, and because of the fact that over 90% of paratesticular rhabdomyosarcomas do have an embryonal histology subtype, they overall have very good prognosis. The one category of patients that we do have to be very careful in are the older patients that present with paratesticular rhabdomyosarcoma. These patients over the age of 10 years do have a higher risk for retroperitoneal relapse, and therefore it is recommended that they receive an upfront RPLND before chemotherapy. Much of this is based on a very old and dated study that was published in the Journal of Pediatric Surgery in 1994, where they looked at the lymph node status of 121 patients. And what they found was that in a very significant proportion of patients with clinically negative staging based on imaging of the lymph nodes, there was approximately 14% false negative rate, and that these patients, especially over the age of 10, had very poor prognosis. And so that's why the recommendations are still standing for an upfront RPLND. So just a few things to sort of summarize. For rhabdomyosarcoma, embryonal type is most common, has favorable prognosis. Majority of paratesticular rhabdomyosarcomas are stage 1. An organ-sparing approach is preferred for bladder, prostate, and genital rhabdomyosarcoma. and vaginal and uterine primaries are associated with good prognosis. So we're going to finish out this session with our final polling question. This is polling question number 3. It says, for genitourinary rhabdomyosarcoma in children, which of the following risk factors is associated with a poor prognosis? Is it age less than 9 years, embryonal histology, the presence of the PAX-FOXO1 fusion gene, a vaginal anatomic site of origin, or a tumor size of less than 4 centimeters? Okay, great. So looks like vast majority of you picked the answer C, which is correct. The presence of the PAX-FOXO1 fusion gene is going to be the risk factor associated with a poor prognosis. So that brings us to the end of our lecture portion today. And so I did want to, again, thank you all for tuning in from wherever you may be. And I'm going to ask Phil to try to summarize some of the questions that came in through the question answer chat box, and we'll see if we can answer those. Just to remind you, we will have the slides available and posted, and hopefully this lecture is also being recorded, so you guys can review it if you do have other questions.
All right, thank you everybody for your participation. Thank you, Dr. Yang, for your presentation. There were a good amount of questions, so I'm going to split up the questions we received based on the 3 sort of malignant neoplasms we had. So for WILMS tumor, Dr. Yang, one of the questions was, why is that flank incision inappropriate in WILMS tumor?
So usually a flank incision isn't going to be adequate in terms of your exposure because there's such a concern with tumor spillage and the fact that you need to do an adequate lymph node sampling. It's generally thought that a simple flank incision isn't going to be enough, so you do need to use a larger transverse transabdominal incision or thoracoabdominal incision. So it has to do with just making sure that you're careful not to have tumor spillage and adequately do what you need to, which is unusual because, believe me, pediatric surgeons usually like to make really small incisions. So.
Okay, for the second question for WILMS tumor, how do you determine histology in low-grade WILMS patients without a biopsy or just therefore upstaging?
So I'm assuming you're alluding to if you have a patient that has a renal tumor and you can't confirm it's WILMS, and usually there are certain circumstances when you can use a biopsy to help you, but because of the risk for upstaging, it's usually not recommended. So based on the what you know from the appearance and the patient's age, they can be treated without biopsy. So making it's an assumption that it is a WILMS tumor, and they can get treated. So in patients that either have syndromic conditions that have a high predisposition for developing WILMS tumor, a bilateral WILMS tumor patient or a patient with solitary kidney, you do not need to biopsy them. They can be treated up front, and that's preferred. And the reason is because it will give you, one, you won't have to automatically upstage them and require them to have abdominal radiation, which has a lot of long-term and short-term morbidity for these patients, but also because you might be able to have a more manageably resectable tumor if you are trying to approach these patients with partial nephrectomy.
Great. The next part is we had a lot more questions about the testicular tumor. We had one question where one of our participants wanted to ask if there's any pediatric evidence that an ITGCN actually increases the risk of testicular cancer, and if you have any sort of new data or studies that address that question.
That's a good question, and that's probably an area that I don't know enough about, and probably one of the questions that I would have to post an answer to after having a chance to review the literature. So most of the studies that I looked at for pediatric testicular tumors and intratubular germ cell neoplasia had to do with the DSD population, and a lot of those case series are very limited just because it's so rare. So it's hard to sort of apply it to the broader patient population of all pediatric testicular tumors. I would say that randomly biopsying the parenchyma of either the ipsilateral, if you do a partial orchiectomy, or contralateral testicle is not really indicated in looking for these precursor lesions. And so it's really tough to say how they play into it. Just remember that the vast majority of the tumors that are going to be in the pediatric population for testicular tumors are going to be benign.
Okay, thank you. Also, a couple more questions about testicular tumors and sort of the surgical treatment or the surgical approach. Would you ever explore testicular tumors, or do you explore testicular tumors through an inguinal approach, or would you actually go for the scrotal, and do you routinely send tissue for frozen path during these particular orchiectomies?
All very good questions. So I think that if based on your ultrasound as well as your tumor markers and metastatic workup being negative, I always approach all tumor processes through an inguinal incision, because if you don't have your diagnosis yet, you don't want to violate those lymphatic pathways by doing a scrotal incision. So even if you somehow knew in advance that it was going to, you think it's going to be benign, you still need to approach it through an inguinal incision. And we basically talk to the families about how we think it's benign, but we don't know. So we set ourselves up to do radical orchiectomy, and then after we get vascular control of the spermatic cord, we basically are able to either biopsy or enucleate the mass and send it for frozen. And we wait for the final their diagnosis on frozen section. If they're fairly certain that it is a benign tumor, we will do a partial orchiectomy. But if there's any question whatsoever, or there's the diagnosis is not certain, we'll go ahead and do a radical orchiectomy through the inguinal incision.
Okay. For the leukemia or lymphoma of the testicle and prepubertal patients, is the treatment chemotherapy? Do we not take out these tumors, or we only do surgery if they regress?
Phil, can you repeat the first part? I'm sorry. Was that regarding, did you say leukemia?
Yes, leukemia or lymphoma in appear in the testicle.
Yeah, so when leukemia or lymphoma appears in the testicle as metastatic spread, a biopsy is not necessarily indicated, and it is treated with chemotherapy, not primary excision. In certain cases where it's either the disease is either resistant or recalcitrant, there is a role for biopsy. We don't see it that often. I think it's only once that I've heard of that that the oncology group has asked us to get a pathology in a patient with a leukemia for diagnosis. It usually can be just treated with additional chemotherapy.
Okay, and down to rhabdomyosarcoma, the last few questions. Do you have any comment about the quality of life and morbidity of pelvic radiotherapy in children, and do you suggest sperm or egg banking in these patients?
Yes, so just to address the fertility issues, we have been really trying to make sure our patients are in discussion with whatever fertility specialists are at their institution, so they know what the options are. So I think depending on the age of the patient and the family's understanding and sort of financial status, that they may be able to figure out some type of banking. For female patients, that's obviously more experimental, more difficult. I don't think that there's any institution, maybe down at Stanford, there might be something experimental with trying to save certain, preserve fertility in female patients, but it's something that should definitely be discussed. And yes, these patients do have very significant, both acute and long-term issues. A lot of them are related to inadequate sort of bladder capacity, urgency, frequency, and a lot of those issues, and then sort of longer term issues related to radiation of the abdomen, including intestinal issues. So that's why it is very important to sort of risk stratify these patients and only be giving the radiation to patients that really need it and trying to spare those others so we can prevent some of these long-term effects.
Okay. I think we may have time for one more question.
Great.
I think people were wondering about the polling question number 2. There were some questions about what the rationale for chemotherapy directly for that question is, and if you could sort of go over your thought process one more time.
Sure. Yeah, I appreciate that, and like I said, I apologize. That's probably not one of the questions that would have made it to the in-service or board, because it was one of those where you just throw in a little detail. But if you read the section on the AUA core curriculum of workup for yolk sac tumor, if there is a biopsy that's done, it does consider that as an upstage. So even though that patient was stage 1 with negative tumor markers and no retroperitoneal disease, because of the biopsy, they then are required to get chemotherapy. So that's the rationale behind that question. Well, it looks like we finished up a few minutes early. I wanted to, again, thank you all for participating. Thank you for your questions. I can be reached over email. Hopefully they'll have some contact information posted for you guys if you have additional questions. And we really hope that you guys are all staying well. Thank you, Phil, for helping with moderating. And again, thanks to the UCSF team.